So the next talk will be by the by Dr. Parul, and she'll be speaking on taming the bulge management of acute corneal hydrops. Dr. Parul.
Good morning, one and all. I thank the AIOS for giving me this opportunity. So I'll be speaking on taming the bulge, management of acute corneal hydrops. So we start with the case. So this was a 24-year-old male with chief complaint of diminution of vision in the left eye for 2 weeks. It was sudden in onset, associated with whitish opacity in the eye, pain, redness, and watering. The ocular examination will be discussed in the photographs. This was the left eye with the acute corneal hydrops, and this was a right eye with the healed hydrops. So diagnosis was bilateral advanced keratoconus with amblyopia. He had nystagmus in both eyes and very poor vision, with right eye healed hydrops and left eye acute hydrops. So what is corneal hydrops? It is estimated to occur in 2.6 to 3% of the keratoconus patients. Most of the cases are seen in the second or the third decade of life. Men are affected more, and there is no racial predisposition so far. Etiology can be primary corneal ectasia like keratoconus, PMD, keratoglobus, and TMD. Secondary corneal ectasia like post-refractive surgery or post-keratoplasty, or other ocular pathologies like infantile glaucoma and forceps-assisted deliveries. What are the risk factors? Eye rubbing is the most common risk factor and the most important, so we advise all our patients to avoid eye rubbing. Then VKC, atopy, Down syndrome, steeper keratometry at presentation is also a risk factor for hydrops, and poor visual acuity at presentation and earlier age at onset. So what is the pathogenesis of acute corneal hydrops? The torn descent membrane causes the rolling of the edges, and a gap is created. Aqueous from the anterior chamber percolates into the corneal stroma. There is separation of the collagen lamellae and formation of large fluid-filled stromal pockets. The DM may retract to form scrolls, ridges, and strands around the attached fragments of the stroma. There is spontaneous approximation of DM to posterior stroma may occur, and it depends on the depth of the DMD. Endothelial redistribution over the intervening area is done and depends on the dimensions of the DM break again. Resolution of corneal edema may occur anytime between 5 to 36 weeks, may leave behind vision impairing scar. So what are the clinical presentation? There is sudden loss of vision, marked epiphora, intense photophobia pain, and antecedent episode of vigorous eye rubbing or coughing. A slit lamp examination usually reveals marked stromal and epithelial microcystic edema, intrastromal cyst or clefts, and conjunctival hyperemia. What is the grading? Grade 1 is within the 3 mm diameter of a circle, grade 2 is up to 5 mm, and grade 3 is more than 5 mm. So complications can be increased. When there is an increased area of corneal involvement, there can be increased risk of neovascularization. There can be increased risk of endothelial graft rejection subsequently. There can be infection, pseudocyst formation, malignant glaucoma, and corneal perforations. So this was our patient with a thickness of 1.8 millimeters, that is 1800 microns plus, when they presented with the hydrops. You can see the intracorneal fluid clefts also in between, and you can see a break in the DM and the separation, that is a rigmatogenous DMD. This is the other eye, which is a case of a healed hydrops. You can see the thinning and the scarring. This was the pentacam of the right eye. So AIOS2025, it shows intrastromal clefts as in our patients, size of the break, corneal thickness, and the depth of the DM detachment. So AIOS2025 shows us DM detachment with breaks and rolled edges, break with flat edges, and no break at all, or a taut DMD. So increased epithelial thickening, stromal thinning at the keratoconus cone, and hyperreflective Bowman's membrane are all risk factors for corneal hydrops. So you can see in these pictures, before hydrops, we have a hyperreflective Bowman's membrane in the first group of pictures, and acute hydrops, these patients develop acute hydrops subsequently. So what is the management? Early management is essential. Spontaneous resolution of hydrops without any intervention takes around 5 to 36 weeks. Increased duration of corneal edema leads to increased risk of corneal complications, so warrants early resolution of hydrops. So what do we give? Conservatively, we give topical hypertonic saline 5% to reduce the intrastromal edema, topical corticosteroids to reduce the inflammation and prevent neovascularization, cycloplegic agents, topical lubrications for comfort, and pressure banding and bandage contact lenses. What are the surgical options? Pneumodesmetopexy and compression sutures. AMT can be done if we cauterize the stroma And tissue adhesives can be used if there is a perforation, or we can also go ahead with penetrating keratoplasty or DALK or lamellar keratoplasty. And some authors have even mentioned a mini DMEC, 5 mm punched out DMEC, which is applied, 3 to 5 mm. So what we gave in our patient, we gave antibiotic, lubricants, atropine, timolol, sodium chloride 5%, and prednisolone 4 times a day. And we did a left eye desmetopexy with intracameral 14% C3 with compression sutures. So this was the pre-op visual acuity, 1800 micron thickness. And in the post-op day 1, you can see how much the corneal edema has subsided. You can see the air bubble, that is a C3 bubble actually. And you can see the compression sutures which have been applied perpendicular to the break. So you can see the drastic decrease in thickness even at the first post-operative day, that is from 1800 microns to 600 microns. Then this is the post-op 1 week photograph showing a thickness of 523 microns. Post-op 2 weeks photograph showing an even further decrease in thickness. So pneumodesmetopexy shortens the period of corneal edema. The agents that can be used are air, 20% SF6 or 14% C3F8. So what is the technique? Preoperative pupillary constriction is done with topical pilocarpine, 2%. AC paracentesis is done to decrease the pressure subsequently, and we aspirate 0.1 ml of aqueous humor. Then we intracamerally inject air, C3F8 or SF6 to fill 2/3 of the anterior chamber. Then we make a peripheral iridectomy, and we advise supine position for 2 weeks and topicals. So we can also give a topical mydriatic agent at the end of the surgery to keep the pupil dilated and avoid the pupillary block. So that is what we did in this case. We didn't do a peripheral iridectomy in this case. So what are the complications? Pupillary block glaucoma, intrastromal gas migration, which leads to the formation of fish eggs, endothelial cell loss, cataract, and Urey-Zavalia syndrome. So compression sutures. Sutures bring the edges of the break closer together and hasten the resolution of edema. It reduces the recovery time, especially in the presence of large stromal clefts. So these are the full thickness sutures, or we can also put a pre-desmetic suture. In this case, we put a full thickness suture. But we can also put a pre-desmetic suture, and that also does the work equally well. So we injected intracameral air to visualize the DM and bring the DM closer to the stroma. And then 2 to 5 pre-desmetic or full thickness sutures. We did a full thickness suturing with 10 nylon were applied perpendicular to the tear, starting 1 to 2 mm from its edges. And sutures should be ideally removed within 2 to 6 weeks. So this is how we mark, after putting a bubble, the edges of the DM, and then we apply the sutures perpendicular to it. So the air bubble helps in visualization of the DM scroll very nicely. So another technique, triple technique, has also been illustrated in literature. That is OCT guided puncture, venting incisions we give, intrastromal pockets we make, and then we do a AC air fill, and we apply pre-desmetic sutures. This is only for very small DM defects. So case number 2 was a 42-year-old female who presented with the similar complaints. Left eye showed this picture. We did a microscope assisted OCT guided left eye desmetopexy with intracameral C3F8 and compression sutures. So you can see that initially it was 922 micron, and subsequently post-op it was 595 microns, the corneal thickness. And you can see the bubble, C3F8 bubble, is not too large. So you fill around 2/3 of the AC only and apply the compression sutures perpendicular to the break. So this was finger counting 3 meter at post-op 6 weeks. You can see how beautifully the cornea has cleared up, and the corneal thickness has become physiological, that is around 522 microns. So what is the take-home message? Early recognition of risk of acute hydrops, like we showed the Bowman layer reflectivities in the AIOS2025 photographs, is very essential. Patient risk factors like VKC, eye rubbing can be managed, and we should counsel the patients. If there is a high risk of hydrops, early surgical intervention is advised. Dr. Susan Jacob has also advised a pre-desmetic DALK, in which she uses a 26 gauge needle, bevel up, and induces tissue emphysema in the anterior portion of the hydrops area, and then manually dissects the corneal stroma. And they give beautiful outcomes. So conservative medical treatment can be started, and based on the size of DM defect, presence of fluid clefts. Surgical intervention includes intracameral gas tamponade, puncture and drainage of the fluid pockets, and compression sutures. Use of MIOCT as an adjunct can be used intraoperatively, and penetrating keratoplasty can be done for very large DM tears, more than 2 mm. Thank you so much.
So, very nice talk, Dr. Parul.
Thank you, sir.
So, Dr. Parul, in compression suture patients, so for how long you continue the cycloplegics?
Um, so for around 1 week, not more than that.
Because gas is in the chamber, you put full chamber gas, na, at the end?
Two-thirds, sir,
Two-third, movable.
Yes, sir, movable.
Okay, okay.
Yes, sir.
And about the sodium NaCl?
Anesthesia? So
No,
we
no,
do it.
NaCl.
NaCl we continue throughout.
Continue.
Yes, sir.
And okay. And what about the suture removal? When you remove the sutures?
So it's mentioned in literature that 2 to 6 weeks. We can even go beyond that.
Because I removed suture in one patient at 6 weeks,
Yes, sir.
and after one week of suture removal, patient again developed hydrops.
Exactly, sir. That's what I said because I also encountered the same thing in one of my patients. So in literature, it is mentioned 2 to 6 weeks.
So
but
now I
ideally
remove
we
at
can-
least 3 months.
3 months, exactly.
At least 3 months
Yes,
later.
yes.
So that will be the better approach.
Better option,
Yeah.
yes, sir.
Okay. Anything, Anu?